This lecture will focus on a detailed discussion of talar fractures. Let's begin. Talar neck fracture is the most common type of talus fracture. The talar neck lies between the body and head of the talus and is particularly vulnerable because it bears significant force during ankle dorsiflexion. These fractures usually occur due to high-energy trauma, most commonly from motor vehicle accidents, falls from height, or sports injuries. The mechanism often involves forced dorsiflexion of the ankle, driving the talar neck against the anterior tibia. In 1919, Anderson first described this injury and coined the term aviator's astragalus, as it was frequently seen in pilots during early aviation accidents when their feet struck the aircraft pedals during crashes. Later, Hawkins introduced a classification system for talar neck fractures, which is widely used today. The Hawkins classification helps assess fracture displacement, joint involvement, and the risk of avascular necrosis, making it important for guiding management and prognosis. The blood supply of the talus is precarious and comes from three main sources. Firstly, the posterior tibial artery is the most important. Its branch, the artery of the tarsal canal, supplies the majority of the talar body, while the deltoid branch supplies the medial part of the talar body and may be the only remaining blood supply in displaced talar neck fractures. Secondly, the anterior tibial artery supplies the head and neck of the talus through dorsal branches. Thirdly, the perforating peroneal artery, via the artery of the tarsal sinus, also supplies the head and neck, forming an anastomotic network. Because most of the talar body depends on retrograde blood flow, displaced talar neck fractures have a high risk of avascular necrosis. Hawkins classification is used to classify talar neck fractures and is important because it correlates with the risk of avascular necrosis. It is divided into four types based on the degree of displacement and associated joint dislocations. Type 1 is a non-displaced fracture of the talar neck. The ankle, subtalar, and talonavicular joints remain aligned. Because the blood supply is largely preserved, the risk of avascular necrosis is low, usually less than 10%. Type 2 involves a displaced talar neck fracture with subluxation or dislocation of the subtalar joint, while the ankle joint remains intact. This displacement disrupts part of the blood supply, so the risk of avascular necrosis increases to around 20 to 50%. Type 3 is a displaced talar neck fracture with dislocation of both the subtalar and ankle joints. At this stage, most of the vascular supply to the talar body is interrupted, resulting in a high risk of avascular necrosis, typically over 80 to 90%. Type 4 includes all the features of Type 3, with an additional dislocation of the talonavicular joint. This represents complete extrusion of the talar body and has the highest risk of avascular necrosis, approaching 100%. Thus, as the Hawkins grade increases, the severity of displacement and the risk of avascular necrosis progressively increase. On X-ray, talar fractures are assessed using AP, lateral, and canale views. On the AP view, a fracture line across the talar neck may be seen, along with loss of a normal talar contour and widening or incongruity of the ankle or subtalar joint suggesting displacement. On the lateral view, the talar neck fracture is usually better visualized. This view helps assess anterior or posterior displacement, angulation of the talar body, and associated joint dislocations. The canale view is a specialized radiographic view used to visualize the talar neck. The patient is positioned supine with the knee flexed to relax the gastrocnemius muscle. The foot is placed in maximum plantar flexion and pronated approximately 15 to 20 degrees. The X-ray beam is directed from posterior to anterior and angled about 75 degrees to the table, centered over the ankle joint. This positioning aligns the talar neck parallel to the beam, allowing it to be seen in profile. This view elongates the talar neck and minimizes overlap from surrounding bones, making it particularly useful for detecting subtle or minimally displaced talar neck fractures and for assessing alignment after reduction. CT scan is very useful in evaluating talar neck fractures. It accurately shows the degree of displacement of fracture fragments, which is sometimes underestimated on plain X-rays. It also helps to identify comminution, especially small fragments around the talar neck or body, which can affect surgical planning. Another key advantage is assessing articular congruity of the ankle, subtalar, and talonavicular joints, ensuring that the joints are properly aligned and that there is no subtle step-off that could lead to post-traumatic arthritis. Additionally, CT is helpful for detecting associated injuries in the foot, which are common with talar neck fractures due to the high-energy mechanisms that cause them. These may include fractures of the calcaneus, navicular, or cuboid, which can influence overall management. Management of talar neck fractures depends on the severity and associated injuries. In emergencies, open fractures must be treated urgently with wound care, antibiotics, and temporary stabilization, because the risk of infection is high. For severely displaced fractures with soft tissue compromise, early reduction is necessary to relieve tension on the soft tissues and prevent skin necrosis or other soft tissue complications. Definitive fixation, however, is not always an emergency. Studies show that delayed fixation does not increase the risk of avascular necrosis, so it can be safely planned once soft tissue conditions are optimized. Surgical fixation of talar neck fractures can be done using a single approach or a dual approach. A single approach may be used in simple fractures, but it often provides limited exposure, which can make reduction and fixation of displaced or comminuted fractures difficult. The dual approach is generally recommended, especially for severely displaced fractures. This involves an anteromedial incision, which allows access to the medial talar neck and body, and an anterolateral incision, which provides visualization of the lateral talar neck and subtalar joint. Using both approaches together gives excellent exposure, facilitates accurate reduction, and ensures that all fracture fragments are addressed, which improves articular congruity and outcomes. The single approach for talar neck fractures is only recommended in simple vertical fractures that have minimal displacement and no comminution. Its main limitation is restricted visualization. The opposite side of the fracture cannot be seen. Any tilting or opening up of fragments on the far side is difficult to assess. Additionally, comminuted fractures of the talus are challenging to handle through a single approach, making it less suitable for complex injuries. The dual approach is the preferred method for displaced or comminuted talar neck fractures, as it provides excellent visualization of both medial and lateral sides of the fracture. It involves anteromedial and anterolateral incisions. The anteromedial approach is made between the tibialis anterior and tibialis posterior tendons, starting from the medial malleolus and extending down to the base of the first metatarsal. During this approach, it is essential to protect the deltoid branches of the posterior tibial artery, as they may be the only remaining blood supply to the talar body in displaced fractures. The medial side of the talus is often comminuted, so this approach allows direct visualization of the fracture, careful debridement, and removal of loose fragment from the subtalar joint, which is important to restore joint congruity and prevent post-traumatic arthritis. In talar neck fracture reduction, the first step is to assess the fracture pattern and identify the non-comminuted side. The lateral or intact side should be reduced first, as restoring its alignment helps re-establish the overall length of the talus. K-wires are used as joysticks by inserting them percutaneously into the fracture fragments. These K-wires allow controlled manipulation of the fragments to correct angulation and displacement while minimizing force on the bone. Once proper alignment is achieved, preliminary K-wires are placed on both sides of the fracture. These act as temporary fixation, holding the reduction in place and allowing fine adjustments before definitive fixation. The lateral or non-comminuted fragment is reduced first, serving as a reference for restoring talar length and orientation. After provisional stabilization, definitive fixation with screws or plates is applied, ensuring restoration of talar height, length, and joint alignment. Key principles include using K-wires as joysticks for controlled reduction, stabilizing fragments with preliminary K-wires, and prioritizing reduction of the intact side to maintain length and alignment. The fixation begins with the non-comminuted side. A compression screw is applied here to provide stable compression and initial stability, establishing a firm foundation for the subsequent fixation steps. On the comminuted side, where multiple fragments are present, a positional screw is utilized. This screw maintains fragment alignment without compressing them, thereby preserving anatomy and preventing further displacement. Alternatively, plate fixation may be employed on the comminuted side. This method restores the length of the talar neck and prevents varus deformity, which is essential for maintaining proper biomechanical alignment. Talar neck fractures carry a significant risk of complications due to the unique blood supply and limited soft tissue coverage around the talus. Soft tissue problems are common, particularly in high-energy injuries. Skin necrosis and wound breakdown can occur, and open fractures have a higher risk of infection. Careful soft tissue management and timely intervention are essential to reduce these risks. Avascular necrosis, AVN, is a major concern because the talus relies on a retrograde blood supply. Radiographs taken 6 to 8 weeks after injury may show the Hawkins sign, a subchondral radiolucent band in the talar dome, indicating that the blood supply remains intact. Absence of this sign suggests a high risk of AVN. MRI can be used to detect early AVN, even in the presence of titanium screws, though artifact reduction may be necessary. Non-union and malunion are potential long-term complications. Non-union is rare, but possible if reduction is poor or fixation is unstable. Malunion, particularly varus malunion of the talar neck, is more common and can alter hindfoot mechanics, leading to pain and abnormal gait patterns. Post-traumatic arthritis often develops even with anatomic reduction. The subtalar joint is most frequently affected, though the ankle joint can also develop degenerative changes if articular congruity is disrupted. Chronic pain, stiffness, and limited motion may occur, sometimes necessitating surgical intervention, such as arthritis. In conclusion, talar neck fractures carry a high risk of avascular necrosis because of the talus's retrograde blood supply. Medial comminution is common, making accurate reduction more challenging. Surgery is almost always necessary to restore alignment and preserve joint function. A 2-incision approach is preferred, as it allows direct visualization of both medial and lateral aspects while minimizing soft tissue damage. Thank you for your time and attention. Please consider liking and subscribing to the channel.